So I wanted to talk about some stuff that you might encounter in the summer that would hopefully be pertinent. Of course, knowing me, by the time that this actually gets out, it'll probably be September, October, so it won't make a difference to you and you won't be able to see it anyway. But maybe you can use it again next year. Anyway, welcome to EMS Grand Rounds. So I wanted to just hit real quick on the idea of grand rounds itself. And you've heard of rounds, like rounds in the hospital. You walk around and you see the patients as you walk around. Then there's this thing, at least historically in medicine, that's called grand rounds. And grand rounds started off with where a learned physician would bring a patient in this big, operating theater in front of all the other learned men, and you would present the case of this patient and, do a demonstration or talk to the patient or show them some sort of physical exam finding. And it occurred in something like this, and that over time has morphed to where we still do grand rounds, but grand rounds now tends to be more like a synonym for conference or education or something like that, where you do have a speaker, and this is sort of the way that grand rounds currently gets held. Still, historically in the big, fancy auditorium, something like that, but you don't wheel the patient in and have them sit there in front of everybody and go through their physical exam findings and that sort of stuff anymore. It's more just a talk. But usually it is, the idea is it's based on cases. So I wanted to give a little bit of a case at the beginning of this, and lots of people do this, but hopefully this is an illustrative thing and not the kind of cheesy case that we normally see people give. So the case. So you are toned out middle of August to a, let's say, 16-year-old male at a football practice who is unconscious. And you arrive, coach gives you a rundown, you see a child, relatively robust adolescent male on the ground in football garb, sans helmet now, who has some sonorous respirations. Coach tells you that basically he's been acting a little bit goofy this afternoon, but then he and another player both ran head-on into each other, smacked, fell back down on the ground. The other kid popped back up, ran back to the line. This kid never got back up afterwards. This occurred maybe 15 minutes ago at this point. So it's mid-afternoon, and the whole team's kind of standing around. They think that his respiratory rate is too slow, so they begin bagging him, immobilize him on a backboard and straps and everything, put a pillow under his head, get some sort of a C-collar sort of wrangled around the pads, even though it doesn't really fit, and they whisk him off to the hospital. There in the hospital, the receiving physician and the trauma team that's been notified ahead of time finds the patient to be likewise obtunded. Pretty poor response, maybe a little bit of posturing. Can't tell whether he's posturing or if he's kind of reaching for painful stimulus with one arm. But they get him fully immobile, or they get him fully undressed, get him off the backboard, and they find no obvious source of injury in this child that they've seen thus far. Pretty clean exam, basically head to toe, other than that he's a robust appearing young male with sonorous respirations and poor response, GCS of somewhere around a 6.5, something like that. So we think that probably he's got a head injury at this point. The decision is made to go ahead and control his airway definitively, so he is RSI'd. He gets succinylcholine and etomidate and an ET tube in his mouth, gets put on some propofol after that, and gets whisked away to the CT scan, where we are, of course, expecting to see a large bleed after the hard hit, and we don't see anything. It looks like normal, basically, brain for a 16-year-old kid. Good gray-white differentiation. We go back through it again and make sure, and yeah, radiologist doesn't really see much. Looks like kind of normal-appearing kid brain. So we go back to the trauma bay. And there in the trauma bay, we find out now the patient has become hypotensive. Initially, blood pressure was something on the order of hundreds or so systolic with a heart rate in the 120s. Now he's down to 80 systolic, and he's become somewhat bradycardic. So we do a quick fast exam. They just did his head before, not seeing anything else. Did a quick fast exam now. It's negative. Now he's hypotensive, of course. They whisk him back to CT scan, do his chest and his abdomen scan. Don't see any obvious signs of hemorrhage or anything like that. And he gets brought back to the trauma bay. At this point, he starts to have a seizure. As he's being transferred back onto the bed, he's given a couple of doses of benzos, stops seizing, then becomes more bradycardic down into the 30s, at which point they lose a pulse and begin CPR. At some point, somebody noticed, man, this patient's pretty warm and well perfused, pretty warm appearing for somebody that seems to be having a cardiac arrest, and it doesn't really make sense for hemorrhagic shock. Maybe it's neurogenic, maybe it's a spine injury, something like that. And about that time, they get ROSC back. So they make an effort to start packaging the guy up to go up to the ICU. They go ahead and place a Foley in him right now. And because it's temp sensing Foley on the monitor, the following starts to show up. Usually equilibrates to about 94 when it starts. And then goes up a little bit. And goes up a little bit. All right, here we are, 98. But it keeps climbing. And keeps climbing. And keeps going. And will eventually max out at about 108 and change. And suddenly the tenor in the room goes, ah, crap. And so aggressive cooling measures are taken to try to get this kid back cool. Ice is put in his axilla, in his groin, and around his neck. We're eventually able to get his temperature back down into the range of about 98 degrees, at which point the aggressive cooling measures are stopped. He is given a bunch of ice-cold fluid in this meantime. Aggressive cooling measures are stopped. The ice packs are taken off. His temperature continues to drift on down and gets lowest of about 93 or so in the ICU. He develops some pulmonary edema from the 6 liters of fluid that he gets, and he does eventually walk out of the hospital, albeit not cognitively the same as when he went in. So, I wanted to talk about, of course, heat emergencies here, which is the ultimate diagnosis on this child: exertional hyperthermia, exertional heat stroke in this case. This is actually probably relatively common, and it's usually not well recognized. Heat illnesses all have to do with the ability to get rid of heat and how much heat we produce. So your body's in a constant state of, where we have aerobic respiration and we make heat as sort of a byproduct, but also the temperature that we keep our bodies at is the thing that lets our enzymes and our proteins and all our cells basically function. And too much out of that, even, a couple 6 degrees either direction, starts to give you pretty significant problems with it. So this is all a combination of how much heat we produce and our ability to get rid of heat and maintain homeostasis. There are various heat stresses that folks talk about. So anything on the spectrum of heat illnesses, like heat exhaustion, where you just feel bad. There's, of course, dehydration, if you lose too much free water. Heat syncope, where basically if you get hot, your blood vessels peripherally dilate, and that can cause, if you've got a little bit of dehydration as well, that can cause you to have a low circulating volume because all your blood vessels are open on the periphery and you just don't have enough volume, and you stand up and take a couple of steps and you pass out. That's heat syncope. Things like heat cramps or prickly heat is out there, but these are relatively minor things. The one that we really care most about, the one that's really dangerous outside of severe dehydration, is heat stroke. And that's what we're going to focus most of our stuff on today. Now, it is worth noting that all these are based on the body's inability to compensate to heat that is either added to the body or produced by the body. This is different than a fever. So fever is a reset of your hypothalamus to where it says we want to be at a higher temperature for whatever reason. We want to fend off these Neisseria or this flu bug, or we took a bunch of medicine and I just think I should be at a higher temperature. Fever is different than exertional heat stroke or the heat illnesses per se. So while using Tylenol or NSAIDs may help with a fever because it helps to reset that hypothalamic response, this is different than heat exhaustion, exertional heat stroke, all that kind of stuff. So worth noting here. Heat exhaustion is the sort of early spectrum of the heat illnesses. Heat exhaustion basically says you feel bad. You have fatigue, nausea, you generally feel weak, you've been out in the sun for a while, maybe your temperature's gone up a little bit, and you're just, oh, God, I don't want to feel, I feel bad. You may get a little bit of a headache, something like that. That's general heat exhaustion. Heat exhaustion is your body saying, we're getting hot, we need to cool off, so it makes you feel bad so that you don't want to do what it is you're doing, and you want to go someplace and get cool, have a drink, and sort of relax. Heat exhaustion, not in and of itself dangerous, but it's sort of the warning sign. Heat stroke is really simply defined. There have been all sorts of attempts to say, oh, this is what heat stroke is, and you'll see like the orange man and the red man that people put out there that are, this is no sweating and high body temperature, or maybe you're cold and clammy, or maybe you do have sweating. The easy way to think about heat stroke, and the way we probably should think about heat stroke is, number one, neurological emergency, but an emergency for EMS. And this is something we got to start treating on scene. So don't forget that before I say anything else. Number 2, heat stroke is elevated body temperature plus altered mental status as a result of that elevated body temperature. So again, not I have a high temperature because I have a urinary tract infection, and that's what happens to old people when they get a little bit of a fever, they get weird. Heat stroke is elevated body temperature plus altered mental status of one way or another, or encephalopathy. And that could manifest as seizures, it could be real confusion, agitation, loss of consciousness, different than heat syncope, of course, but actual loss of consciousness like this child I described. They, of course, have a high body temperature, and that is defined as a temperature greater than 104. The reason it's sort of set at 104 is because under 104, yeah, you could get heat stroke type symptoms. However, it's less likely, and it's more likely in that case that something else could be going on. Again, you have a fever, or you've taken drugs or something like that. So high body temperature. There may be sweating, especially in exertional heat stroke. Marathon runners often will be covered in sweat, and their temperature still be 108, so sweating really has nothing to do with it. They could be pale, their skin could be dry, it could be red, it could be white, it could be green. It's hard to tell. The skin condition really doesn't make a big difference. Okay, so we mentioned the difference between heat exhaustion, which is I'm hot and I feel bad, versus heat stroke, which is I'm hot and I have altered mental status or encephalopathy in one way or another. And again, it's a high body temperature greater than 104. The condition of your skin doesn't matter. The amount of sweating doesn't matter. It's elevated body temperature and encephalopathy or altered mental status. Those are the things that make heat stroke. And when you see that, that is a neurological emergency. That is an emergency as much as a stroke or a STEMI or anything else you're going to see is. So what's actually going on during heat stroke? What's sort of the biomechanics and the pathophysiology and all that stuff? Well, again, this is a difference between how much your body is able to get rid of heat and how much heat you produce, or how much heat is put into you. And in this case, heat production, for whatever reason, outweighs your ability to get rid of that heat. So to take it way back to high school science, and maybe even, this is probably elementary school science, if you remember, there's a couple of different ways that heat can be lost from one object into another object. Convection, evaporation, conduction, and radiation. To hit those real quick and put them in good terms, straight up conduction. You jump into a cold pond, heat leaves your body directly and conducts into the ice cold water itself. That's loss of heat through conduction. Likewise, you can gain heat through the exact same path. If the water was hot, it would go into you. That's that's conduction. That probably makes up most of what happens again when you jump in like an icy pond or something like that. Radiation of heat is where we at rest lose most of the heat in our body. We don't think of it very often, but most of the heat that, again, is us at rest, we lose most of our heat just radiating it out through the RF spectrum into the atmosphere. Again, that's at rest. When you get under exertion or when you get in different conditions, that changes a little bit. Convection is when you have an air current moving over the body or moving over the thing, so that heat is taken away through basically through that air current, through that air particle, and gets kind of blown away. And this can be where you lose a lot of heat. How do we lose heat through convection primarily? Well, if the air is moving, that helps with, say, sweating. If you can increase the convective heat loss when you get air that gets hot and bubbles away from you or is blown away from you, then you can lose a lot of heat that way. That's why you may get hypothermic even on a 75-degree day. You get a little bit wet, the wind starts blowing, and your body temperature can actually drop fairly low. And then there's the main exertional heat loss method that humans have, which is sweating. And this is evaporation, basically. You take the water that comes out of you, and then your body heats it up, puts enough energy into it that your body loses the heat, and the water goes away as evaporation. So those are the ways that we have to sort of lose heat into the environment. So what does heat stroke actually do? Yeah, we get that you get too much heat in your body, but how does that actually affect your body? How does it make it not function the way that it should? Well, there's kind of two different camps on it. One says that your temperature goes up and your hypothalamus reacts and says, okay, skin vasodilate, let's try to get the blood pressure back, or let's try to get the body temperature back down, so you peripherally vasodilate. When you shunt blood away from your organs and send it out to your skin to try to lose heat into the atmosphere through evaporation and convection and conduction and all that stuff, then things like perfusion to your gut may decrease because you don't have that much fluid circulating around through your body. When that happens, when your gut sees less blood flow, it gets unhappy and starts to get inflamed, and the inflammatory mediators come in there, and you get all the same stuff that you might find as like toxins leak across your gut wall, and there's endotoxins, exotoxins, and all that kind of stuff, and bacteria can get across there, and you basically get the similar response to like if you had a sepsis type picture. This big inflammatory response that may be due to, we think, decreased perfusion of things like your gut, which gets preferentially blood shunted away from it when you get really hot as a result of trying to cool your body off. The other thought is that as your temperature goes up, you simply denature proteins, and the enzymes and proteins that are in your body stop functioning, because we know they work in a pretty narrow window. So just like Jell-O, as that temperature goes up, those things denature and they kind of fall apart, and they stop performing their function because their function is mostly related to their structure. And when you take the structure out because it gets a little bit too hot, then they stop doing what they're supposed to do. Let's talk about the flavors of heat stroke itself. There's exertional heat stroke, which is what we typically think of usually in developed countries in the United States especially, although there are some developed countries that have big problems with classic heat stroke as well. We'll get into it in a second. Exertional heat stroke is when you make too much heat in your body for your body to be able to lose effectively. That can be because there's too much heat in the air around you, you can't get it out there. It could be because you're in a very humid environment and you're insulated, or because you're wearing firefighter gear and you can't have that convective radiation, really effective evaporative loss. All that is possible. But this is because you are doing something to raise the amount of heat in your body, and you can't lose it fast enough. So where do you typically see this at? You typically see this in people that either can't stop doing what they're doing, or are so driven that they won't stop doing what they're doing, and they push past the feeling of, I don't feel good, I'm at heat exhaustion, I would like to stop now. They continue to go on. So you see this in, again, not forced marches, but compelled marches, like people at recruits at basic training, something like that, where they tell you have to keep going, you have to keep going, or there's pressure on you to keep going and you can't stop. Likewise, we'll see this a lot at marathons, where people are driven. They've been working for a year and they feel bad, but they keep on going anyway, and their temperature gets super high if it's, say, sunny and a little bit humid. They don't lose heat effectively, and they can get heat stroke because they're driven to keep going and not stop. We may see this in firefighters, again, because you are trapped, maybe not trapped in a burning building, but you're stuck in a hot environment in hot clothing that does not lose heat very well, and so firefighters get heat stroke. And then sometimes you'll see this in folks that can't get out of the sun for whatever reason, because of their job or because of their situation or their environment. If they're working hard, they may develop exertional heat stroke. Now, this is a little bit different than classic heat stroke. Exertional heat stroke, I'm doing a bunch of stuff, I'm building up heat, and I can't lose it fast enough, and I can't stop or won't stop for whatever reason. Classic heat stroke is a little bit different. Classic heat stroke is typically a disease of the old and of the very young. And this is where the environment puts so much heat into you that it overwhelms your body's ability to get rid of heat. So where we'll classically see this is in when they talk about like heat waves. There was a heat wave this summer in India that killed a number of people. And the reason is when it's hot for a long period of time, eventually you overwhelm the body's ability to get rid of heat. And so this, while exertional heat stroke may happen over the course of a couple minutes to hours, this is something that usually happens over the course of a couple of days. It's not usually the temperature went up for one day and then it came back down, but it was just really hot that one day. This is more like it's been 110 degrees every day for the last week. And so again, who gets affected by it? Folks that can't do stuff to get rid of that heat more effectively, i.e. the elderly and the very young. Things that would make you more susceptible to that sort of heat stroke would be a number of different drugs. So another reason that the elderly might be more at risk, because they're usually on a number of these drugs, at least in theory. There's certainly some illicit drugs that will do it, as well as basically all the neuroleptics. Anything that's got serotonin activity can potentially make you more likely to develop heat-related illnesses. Of course, things like cocaine, the anticholinergics like Benadryl or Jimson weed or something like that raise your body temperature. You know, hot as a hare, mad as a hatter, all that stuff. Things like aspirin can potentially do it. And then there's the withdrawal symptoms too. So removing baclofen or alcohol or benzodiazepines from your system rapidly can cause you to have an elevated temperature and heat-related problems, or make you less likely to be able to move heat out of your body. So how do we make the actual diagnosis of heat stroke? How do we determine who's got this, and what do we do about it? The diagnosis itself is made pretty much the way that I told you before. Heat stroke is a combination of elevated body temperature and altered mental status. And that's the definition. That is what it is. You don't have to have all the different signs and symptoms. Basically, again, elevated temperature plus altered mental status, which can be any of those things that you see up there, is sufficient to diagnose heat stroke. Now, of course, again, it has to be that they're not altered because they have a fever or they have meningitis, and subsequently their body temperature is elevated. It has to be presumably causative in that clinical picture. But this is I do like this graphic here. These are from the Raw Medicine guys, RAW Medicine, which is wilderness and austere medicine. Basically, this is a great way to kind of dumb it down a little bit, or to make it easy for all of us to remember. It's not the condition of the skin, it's not whether or not they're sweating, it's their body temperature and their mental status, and that's heat stroke. Should we be measuring body temperature in these people in the field? Because again, we're talking about EMS here. There, again, sort of two different thoughts on it. If you find somebody that feels hot, we're not that great at figuring out like what an actual temperature is, but you can usually tell somebody that's hot. Should we just go hot with altered mental status and say that's enough to do it? Or should we be actually measuring a body temperature? I'm in the camp of, if we're EMS, we should be doing things right. We should be getting a relatively accurate body temperature. And it's not a temporal scan. It's probably not the ear stuff. It may be a thermometer under the tongue, but this is very variable. If the person just had something to drink, or if they're breathing really heavily, that may give you a false reading. A good body temperature, an accurate body temperature in this case, is hopefully done with a rectal temperature or a bladder temperature. If you had the person intubated, you could get an esophageal temperature. Now, that's not as hard as it sounds like to make happen. You can get a rectal temperature probe it's this like kind of skinny wire that you can get up there, and it just takes a little measurement device, a little box that goes along with it. It's not impossible to do. It's just more work than I think most people have wanted to put in thus far. But I say, if we're going to do this, if we're going to treat people, if we're going to take the credit for treating people and do the stuff for treating people and providing critical care, bringing it out into the field, then we should be measuring body temperature, and we should be measuring it accurately. So I would say, yes, you should measure body temperature, and it needs to be rectal if you're going to do it right. But of course, there's the other camp that says, well, maybe you should just treat them aggressively. The only thing I have to say about why we shouldn't just treat everybody aggressively without knowing their actual temperature is because what if you have the kid who's been playing football and his body temperature's up to 101, 102, and he feels hot, he looks hot. But if we think he has heat stroke, then what we need to do is stay on scene and get this kid cool. Whereas if we think he's got a neurologic emergency otherwise, if we think he's got TBI or a brain bleed or something like that, if we think he's got intracranial hemorrhage, on the other hand, or hemorrhage into his belly or something like that, then we shouldn't be sitting on scene trying to cool the guy off. We should be getting him to someplace with a surgeon and maybe a neurosurgeon and a CT scanner. So in that case, just the presence of feeling the kid's temperature itself may not be sufficient to give you the whole clinical picture. So I'm again on the mind of, let's do this right, and everybody should have the means to get a relatively core body temperature, preferably in the rectum. If you're critical care paramedic, you could put Foley in. Just saying. Anyway, I think it should probably be rectal, and I think you probably should do it and not just base your treatment on this very important thing on your, like, putting your hand on the kid's forehead or person's forehead. What do you do about it? After you made the diagnosis of heat stroke, how do you treat this? Because I've told you, I've said now a couple of times, this needs to be treated aggressively. Lots of stuff has to happen, and this is something you should stay on scene to initiate treatment on. You can't wait till they get to the hospital. What is the stuff you actually do? We'll talk about it in a minute. All right, so we've made the diagnosis of heat stroke. We've got a person who has an elevated body temperature because we've taken a rectal temperature, and he's got ultramental status, seizures, encephalopathy of some kind, elevated body temperature plus ultramental status in the right clinical picture. Mwah, the diagnosis of heat stroke is complete. What do we do about it? You got to be pretty aggressive when you're treating heat stroke, because true heat stroke, you basically think of it like a stroke. Neurons are dying every minute that his body temperature remains at 108 or 109. So we've got to be aggressive about it. We've got to initiate treatment on scene. Waiting until you get to the hospital and letting somebody else kind of screw around with it for a little while, that's going to take too long. So we've got to start treating heat stroke on scene. And this is probably something that if you make the diagnosis of it, because this is a runner and you're expecting this to happen or something like that, then yes, you should probably stay on scene and begin the treatment early. How do you get the person treated? Well, you basically try to get them cold. You turn them into a block of ice as rapidly as you can, and maybe not that cold, but you need to aggressively take heat away from this patient's body. Again, this whole thing is a discrepancy in the amount of heat that we produce and our ability to get rid of heat. So we want to decrease heat production as much as possible, and we want to increase our ability to get rid of that heat. We want to do that through all available methods, including conduction, radiation if at all possible, convection, and evaporative methods. So the best way to do it, about the fastest, most efficient way to get this done, is to immerse the patient in cold water. And the way they've got this set up here is a horse trough or a stock trough that is filled with water and ice, and they agitated that up beforehand, and they had the person sit down in it. They've got a cold towel over top of the person's head to get cold water up on top of the head itself. You notice that this well-prepared person has a little box there that's actually a temperature gauge, and it's going down, and you see it disappear under the water right up into the guy's bum. They are accurately measuring temperature, and then this cat here is there, of course, to keep the person from drowning and going underneath the water, which are all critically important things. Now, this is great if you have this set up after your wilderness, ultra marathon or your marathon down on blacktop or something like that. If you know it's coming, you should have one of these available to you and ready to go, so that you can dunk the person in it. You shove that thing up in there, and you watch their body temperature come down over the course of 15-20 minutes from 108 to 102, something like that. Cool. What if you don't have this available? What if this is, like I said, you get called out to an unexpected heat emergency? There's some things you can do to improvise. One is this tarp-assisted method, so the TACO, the tarp-assisted cooling with oscillation. What they've basically done here is take a regular tarp, they have put some ice and some water in it, they set the person down in it, and then they got a bunch of people just holding the edges of the thing up, making like a little bowl that the patient sits down in the middle of, and then the oscillation part is them kind of kicking it with their knees and jiggling the thing around so that the water circulates through there. This is nice because you can improvise it. All you need is some ice and some water and a tarp, and you plop the patient in the middle of it, and you make a little swimming pool, basically. And this is a pretty efficient way to do things. You know, if you look at this graph, it basically says if you got people to raise their body temperature and you just let them sit passively, it takes about more than 40 minutes for their body temperature to go from 39.5-ish down to a normal range of 38.5 or 38.0, something like that. Whereas if you use the TACO method, the TARP method, then they went from a temperature of almost 40 degrees down to normal body temperature in about 9-10 minutes. So really drops you down pretty quick. And the same thing you'll find happens with the use of the big horse trough or something like that. So immersive cooling is a very efficient way to get this done, and it's much better than passive cooling. If you're passively cooling somebody, meaning you put them in the shade basically and you take their clothes off, it's going to take you an hour at least before their temperature comes down even a couple of degrees. So you have to do something active, and immersive cooling is about the best way you can do that. If you don't have that available, there are some other options. In this case, these guys are using convection and evaporation for it, so they have a fan blowing there that will increase the convective transfer of heat across their body, as well as some mist, so fine particles of water that will help to evaporate, and you lose heat that way. When you're doing convective heat loss, if you just get the person wet and then put a fan on them, they lose about 1 degree Fahrenheit for every 10 minutes of active cooling in that way, which is better than nothing, but not as good as the immersive cooling. But this is also relatively easy to do. Most fire trucks somewhere around there have some sort of wind-blowing device. It could be a leaf blower, it could be a fan. And most of the time we're able to find water around fire departments, around most scenes without too much problem. It doesn't have to be cold water per se. You just have to get the patient wet and then put some sort of air current moving over top of them. Should you use ice-cold saline? This is brought up. Everybody wants to give these guys cold saline for some reason, because we've heard that, well, I know the reasons, because we tell people, well, if you give people saline at room temperature or cold, then they get cold. And that's true, but when you look at the actual thermodynamics of it, if you take a 100 kilogram specimen and then add 2 liters, 2 kilograms of ice cold water, if my temperature is 108 and you toss in 2 liters of water, assuming that distributes and doesn't pick up any more heat from the environment on the way there, my temperature goes down by 1 degree or maybe 1.5 degrees, something like that, Fahrenheit. And that's not zero, but you can't use that as your sole means of cooling the person down. So don't think that if you've got somebody with heat stroke, you're doing them a huge favor by giving them 2 liters of saline, even if it's ice cold, because that will only drop by a couple of degrees. And we gotta go more than a couple of degrees. We gotta go down 6, 7, 8 degrees, typically speaking. So if you are going to do it, it's a good idea to use at least an isotonic or maybe a slightly hypertonic solution. Most of these people actually don't have a huge free water deficit, especially the exertional heat stroke that we'll find. Most of them don't need a whole lot more free water. They need some volume, but it's usually best for the noggin, for the brain up there, if you have something that's at least a little bit more a little bit hypertonic, or at least isotonic, with everything else you're giving them, and avoid giving a bunch of just free water itself. Now, one thing to sort of bring up is there is this possibility of this thing called exertional hyponatremia, which is where your kidney, because of the way that you're shunting blood around, your relative hypovolemia, you excrete more sodium, at least your kidney finds, and your sodium drops. And sometimes it gets, relatively low. If you were to measure it down into the 1-teens or something like that, you could have such a bad hyponatremia that you get seizures and have all the stuff that happens with hyponatremia. So you do have to watch that. In severe cases, it can be really hard to tell what's the exertional hyponatremia aspect, unless you have a point-of-care lab like an EPOC or something like that, versus what's the heat stroke component of it. So you do have to watch out for that. That does exist. It's going to be very difficult to make that diagnosis in the field. However, if you were, again, to measure a core temperature and find this patient's temperature is, he's been exercising, but his temperature is only 102, but he's seizing, then you may lean much more on the side of, well, we should consider that this could be hyponatremia. The other thing I didn't mention was that a lot of these guys, of course, will drink water, which is provided to you, but a bunch of free water without a bunch of solute in it can lead to this as well. And you can actually dilute your sodium out so much, in addition to the kidney dysfunction that happens with it, that your sodium gets that low. So good reason to avoid a ton of free water if you don't need it. Hydration is not necessarily the key. It's balanced solutions. It's balancing things out. So long story short, watch out, because exertional hyponatremia is there. Treatment for it is to administer salt until they stop seizing, which is usually in the form of 3% saline, something like that. One of the other things I didn't mention thus far is keep in mind that you are constantly getting bombarded with radiative heat, usually from the sun. So anytime you're dealing with somebody that is in a state of hyperthermia, you want to avoid throwing more heat in on top of them. So getting them someplace in the shade will help with that. Certainly, you don't want to sit out there for 15-20 minutes in direct sunlight if you can avoid it. I'm trying to get them cold. Well, you're constantly getting bombarded with more heat from the sun. Get them someplace else. Now, that works best if the air temperature itself is relatively low, down into the 70s or something like that. But it's worth mentioning that keeping somebody out in the middle of a field and trying to get them cold may be better served to move them 50 feet off to the side, get them under the shade of a tree, and then we'll cool them off aggressively. By the way, how about ice packs in the groin and in the axilla? Is this effective? Probably not that much, honestly. You would probably be, in fact, not probably, you would be better served. You would cool the patient much faster if you were to take the ice out of the packs and cover their body with it, to cover their skin, because it's not just your axilla and your groin that they think this is where the big blood vessels are. In this case, you're trying to get the whole body colder because it's a whole body problem. So spread the ice over top of the patient. You can probably use like if you need to help keeping it on there, you could put a little sheet on them or something like that if you've got ice over top of the person, because that conductive heat loss is so great. So ice packs in the groin and the axilla, not very effective. Ice packs all over the body or covering the body in ice, not in a pack, probably a better idea. And this is just a review of all the stuff that we've kind of talked about so far. Again, cold water immersion, probably about the best thing. Tarp-assisted cooling works real well, almost as good as the cold water immersion at getting temperature down to where you want it to be. Just getting them wet does a lot. You can do rotating ice towels, not quite as effective. Passive cooling, not all that helpful. Again, if you're going to get somebody down from 43 degrees to a reasonable temperature, it's going to take almost 2 hours, which is way too long, and the patient will have terrible brain damage by that point. So don't do passive cooling. You've got to do something else. And then putting ice packs on the groin and the axilla, interestingly enough, seems to take longer than even passive cooling. So skip the ice bags on the groin and the axilla. If you're going to toss stuff on them, just toss ice on top of them, and then put a fan over top of that. That works very effectively as well. So do something other than nothing, and don't do the ice bags on the groin and the axilla. Now, what about shivering? I pop this patient into the vat of water and they start to shiver. Do I need to give them paralytics or benzos to stop them from shivering because maybe they're generating heat when they shiver? The amount of heat that you generate is probably about a degree or so. Your ability to raise your body temperature by shivering probably maxes out at like a degree, maybe a degree and a half. That will be a drop in the bucket when you look at how fast you're going to cool this patient otherwise. When you plop them into this into this vat of 32-degree water, you will overcome the body's ability to. They will continue to shiver, but you will overcome their ability to generate heat by doing so. So go ahead and just toss them into the water. Don't worry about the shivering. Don't give them benzos because you're worse in their mental status and they'll fall in and drown. You will make them colder if you're doing something like this, which is about the way that you're probably going to get the most shivering response. Now, how cold are we actually going to get? Are we going to get this guy down to 98 degrees and then stop? Keep in mind that your body is sort of layered. So we want your core to get cold, that's true, but we have to cool sort of through the skin. So when you put ice packs on somebody, by the time the core, which is where we'll get a rectal temperature or bladder temperature, by the time the core gets relatively cold, that means that the skin is going to have to have gotten a lot colder. So ideally, you're going to stop cooling the person actively when they get to about 102. So 102 Fahrenheit, you can go ahead and remove the active cooling stuff. They'll be out of the woods for the most part, but then they will continue to lose heat because their skin, where you have the ice packs or you have the evaporative cooling, is going to be colder than 102. And you will eventually equilibrate out to about a normal body temperature, theoretically, as long as they're not generating a whole bunch more heat at that point. So when you get to 102, stop the active cooling. If you let them get to 98 degrees core temperature, they will probably continue to drop down by 3 or 4 more degrees, and that's where you get that kid that, again, we stopped at 98 degrees. We took the ice packs on him when he was at 98 degrees, and he went down to 93. You don't need him to get that cold. When he gets to 102, take the stuff off, and he'll continue to cool down from there. The takeaways from this. So, Heat stroke is a high body temperature plus ultramental status, and I think you need to take the temperature if you're going to make this call. So have some way to get a rectal temperature out there, whether it's a thermometer. Ideally, it's a temperature probe with the little box on the end of it. They're not that expensive, and you're not going to use it all that often, but when you do need to use it, it's going to be super helpful and potentially life-saving. The treatment is taking the heat away, and that has to start right away. It has to be stay and play if that's the concern. If it is heat stroke, then as fast as possible, we need to get the heat taken away from this person. There's probably a limited role for IV fluid, although it's not going to hurt them to get probably a liter or so, and it gives you a little bit of benefit, but don't rely on that. That can't be your sole means of cooling this person down. And again, this is a stay and play thing. Now, if the person was involved in a motor vehicle collision and you think they may feel hot, but you also think that they have terrible broken pelvis and they've got intra-abdominal injuries and a head injury and everything else, and you decide at that point that we are going to go to the hospital, that's a reasonable thing as well. But the marathon runner who is running along and gets to the finish line and then looks like death and kind of collapses, who has a elevated body temperature, that's somebody that we need to stay and play on when the clinical picture fits a heat stroke picture. For more information on this, check out the Wilderness Medical Society practice guidelines. There's actually a more recent update than 2014, but this has all the stuff you would want to know and more, where a lot of the stuff from this presentation came from. Check this out. It's good reading and gets into all the nitty-gritty on all this stuff too. Likewise, you can check out the Raw Medicine podcast made by some good austere and wilderness medicine practitioners out there. You'll enjoy it. They have a good section not only on heat emergencies but on all the other stuff that you'd be interested in as a wilderness medicine aficionado. So that's what I've got on heat emergencies, and we'll see you next time.